Hear me? Well, yes. Cool. Awesome. And I know we're, I can try to make up some time because honestly, I'm like, I don't know if 30 minutes to discuss all this stuff, but it's cool stuff. I mean, I can spend hours talking about it, but I don't know, can anyone else? So let me go through what's called the direct care. I'm going to phrase this more as like my journey because I think it's intersecting. And I'm going to specifically talk about how, like, what I learned and how it applies to what I think medical students should know because direct care is a type of private practice model, and we'll talk about what that means in a second. But the vast majority of us are not going to go into direct care, nor should everybody go into direct care. I'm not advocating this as like this is going to fix medicine. This is just one model of doing medicine that I found helpful for my like, personal style. So just a little bit about me. So I'm a psychiatrist. I specialize in ADHD across the lifespan. Right now I'm in private practice. I own a boutique practice called A Plus Psychiatry. My whole life I was like all gung ho about academia because I love like with having ADHD myself. Like I love the variety of academia. I love like the teaching and then the clinical stuff and then the research, it's all that. The problem was that when reality hit, I got hired. And everyone talked about a lot of stuff already. It's definitely that people pleaser. This is great. It just doesn't work when you're trying to love it all, do it all, and be a people pleaser and work in a major academic center. It's a recipe for burnout. Trust me. I tell you about that. So I did to be clear, okay, there's people who work great at large medical centers, work great at large group practices. They thrive. And I want to make that clear. This is not about like, this is the right way or wrong way. It's just for me, the way it is. I happen to have a style where I like to take my time with patients. And I get very, very nervous when I push to move faster than I want to move. And so, like, I kept running the same problem over and over again. I'd stay through my lunch break. Basically what it was is I would be doing a lot of like.
That was a joke.
Uh, okay, so okay, no, okay. Long story short, I left during the pandemic after burnout, and I went to a community health center. That was cool. I did have more time and flexibility, and there's a big lesson there. So it's not just about time. I thought this whole time, like, oh, it's just I just need more time with patients. I'm just not getting rewarded for spending time with patients. Well, when I worked the place that had time with patients, I was still not happy there, and it had to do with more about the fact that my values, my brand, what I have to offer was just not in line with what I was being paid to do or supposed to be paid to do. And I guess that's the first teaching point for the medical students, I think, is thinking about your own personal brand. And this sounds like a cliche, but it's so true. And it's maybe even for the law students too, even for anyone. And like, who are you? And that takes a lot of self reflection, right? For a while, so I worked with a consultant coach, and Jenny Burton, we're going to hear about shortly. And she, had me like spend a lot of time. And I would encourage you guys to do the same. Like, think about your high points in life. Think about the times, not just the times where you were rewarded or told you did a good job, but the times where you were truly happy in life. Like, and think about what does that tell you about yourself and your values. It turns out when I'm truly honest with myself, what I really want is I just want to have fun in life, right? I want to have fun. I mean, I'd love to say, I want to save lives. I want to do all that cool stuff. That's fun. But like, I just like, so how do I design a practice that's fun? Well, for me, fun means variety, challenge, reward, right? So I kind of stumbled my way into the direct care model, and I guess that's what I'll talk about. So what is this direct care thing we keep talking about? All right, so this is based on what's called a direct primary care model. Direct primary care is a way of doing, it's mostly for primary care, where patients pay a flat monthly rate directly to the practice. So that's why it's called direct, right? Everything goes directly to the practice for basically unlimited care. The idea being that patients, like, so for example, they may pay 100, 150 a month. It's different. There's pediatrics, there's, adult medicine and all that. Most direct care providers have much less patients. For example, average about 600, which sounds crazy a lot for primary care. I can imagine 600 as a specialist, but like, and then versus 2,500, would be a typical primary care thing. So you get a lot less, you get a smaller panel, patients are working directly with you. If you think about it, it lets you design a practice. It's a pioneer approach. So, I mean, it is and it isn't. I mean, this has been around forever, right? But like, from where we are, imagine if you could practice like a way that was agnostic to insurance, agnostic to fee for service. Like, how would you design that practice? And that's kind of what I think the direct care model is. Well, patient's going to pay a flat rate. It's going to cover their care. I use a lot when it's heavily involved in technology and stuff. Because if you're agnostic to insurance, it doesn't matter, for example, if a patient calls and needs a 15-minute phone appointment. For me as a child psychiatrist, here's a classic example. This happens all the time. The insurance requires the patient to be physically present for me to bill, right? So if I want to have an appointment with a parent, let's say a parent comes and they say, I just need to talk to you about my kid. You know, these things are going on, and like, it's just not appropriate for the kid to be there for whatever reason, because you're going over sensitive stuff. I couldn't bill for that. I mean, you could in a roundabout way through some family therapy and stuff, but not really. With a direct care model, it doesn't matter when I'm a child psychiatrist. It just doesn't matter. I'm doing what's best for the patient. If that's a 15-minute phone call, that's fine. If I'm in an appointment with a patient and he or she's crying or having a moment, and different adults too, it's totally fine for me to say, okay, can we just schedule, let's just end it right now and schedule again next week. I don't have to worry about, am I going to bill them? Is this going to be okay? Did I medically justify this? No, it's just the right thing to do. So it really does lead to much better patient care. I'm also much more, and this is again part of that branding thing, and with my take-home points, I'm much more open with my patients. So, for example, my patients all have my cell phone, well, my work cell phone number. A lot of direct care models are much more tech-heavy. So, for example, my patients have a cell phone number that's directly tied to their medical record. They text the record, I get it on my phone. They text the number, sorry, the SMS number. It's immediately attached to their chart. So if someone says, hey, doc, can I have a refill on my Prozac? I say, sure. I write back in the text. I go on, and I can do it on my phone. Just go and refill it, done. And that text conversation is actually part of the chart now, which is amazing. Now, you worry, like, I was worried about this all, like, okay, so patients paying a flat rate, they have 24-hour access to me. But this is like, this is a recipe for disaster, right? And you would think, oh, how many calls do I get in the middle of the night from patients in crisis and stuff? But that's where I'm transparent about it. I tell patients when I'm onboarding them, I say, oh, I have a life. I joke, I don't. But like, that's funny. That's my style. But like, I'm like, look, I pretend I have a life. If you text me at 3 in the morning, I'm telling you right now, I'm not gonna answer that phone. If there's an emergency at 3 in the morning, you better call 911 or something and text me in the morning what happened. I will do my best. And the crazy thing is that you would think like running it this way is like, oh, just like in classical, medicine, we talk about being people pleasers. This like it sounds, but it works. My patients dig it. And I tell them flat out, I'm like, look, guys, I have ADD. If I say I'm going to do something and I say I'm doing it and I forget, I'm sorry. And actually, like, for a while, actually, I was like really worried about that. Is that something from a liability malpractice standpoint? But actually, I set the expectation for my patients. And I think that actually protects me in a way. I'd love to geek out with an attorney about that. That's not what we're here about. But I just say the expectation, like, yeah. But it really does help. In that model, my patients, we get each other. Like when I start my business patients, I might just have a 10-minute payment here or there. I don't care. Now, a couple of things there. And I do want to open this up for debate or discussion because I'd love to hear. I did modify my model, so as a so the true model is flat rate. What I discovered, at least in as a specialist, like a lot of patients have a cheap complaint and then they're fine and they don't need to pay. So now we offer a hybrid approach, which actually helps my next teaching point about what we need to do to get this movement going. I think is we need more data, especially like, and I have data. No one's asked for it yet. I'm waiting for someone to ask me for my data. But I have data on how many patients I've seen, how long I've seen, how much I spent on phone calls with the patients, and stuff like that. Because then we can go back and say, if we want to scale this, let's say to insurance companies or whatever, we need data for them to know how much it's really going to cost them. Now, that brings up another thing that I really want to discuss is this model really is a boutique operation. It only works for patients who who can afford me, right? It's not good for low-income patients, and I think about this a lot. Now, I try to give back by teaching. I have students with me. I give discounts, things like that. I'm always looking for ways to make it cheaper. But this is one thing that I think a lot about is that I don't ever say this is a great way. This is agnostic to insurance. This is a good way to improve. It's 21st century. Everyone can't do it though, because then who's going to take care of everyone? So I'd love to know thoughts on that. Like, is the way to go to scale this up, through insurance? Is this something that really is only for certain people who have a pioneering spirit? And so that was a couple of other things. And then one other thought there. Well, actually, I think I'll stop right there. I think that's a good stopping point. Just open it up.
So I have just a couple of clarification questions. One is, so if you prescribe a drug for the patient, who pays for that? The patient? I mean, how does that work?
So The actual cost of medicine I just go to the pharmacy for, but like anything else, I'm just a doc. So the way I really do it, I don't even know. It's like I do like free play arcade. You know, you go to like Dave and Buster's or Chuck E. Cheese. You know how you need to like pay tickets, like tokens for the skee ball. But like what I have is basically a free play card. So basically, patients have an option. They can pay per visit like normal. That's like the pay as you go for skee ball, or they can have an unlimited. And I frame it more as a financial thing. Like rather than paying me $250 per half hour, you just pay me a flat 200 per hour. Yeah, it's like 200 per month. I don't know if that answers the question, but otherwise it's essentially the same as a fee for service. It's just I'm getting paid a flat rate per month.
But if they need an expensive drug, do they have such standby, do they have, ancillary insurance?
Oh, this is yeah. No, part of the agreement is, and I should have made this clear. I am not insurance. In fact, it says that specifically in the agreement that patients sign. This is not insurance. This is just a model of care that we're going to pay out of pocket for unlimited visits and direct access rather than that. Often there's people confuse this with concierge care. It's not the same, and that's why I really frame this as this is like the unlimited package. I'm not a concierge doc. I have hours and stuff like that. One of the thoughts too, before I forget, and I want to know again, I want to hear other people's thoughts on this. One of the things that direct care model allows for that I would love to explore is going directly to the employers. I would love to have a contract with, say, Case Western School of Law. You pay me for a direct model. I'll be your doc, your psychiatrist or whatever for how many patients. Pay me. It's cheaper. I figure it's going to be cheaper for the law school or whatever, as an especially direct care model, or go to Progressive and have, I would love to see it. And the direct care model does allow that, where let's say you could go to a large corporation like Progressive and say, you know what, I realize you're paying for insurance, but it might be actually cheaper if you just pay a physician some money to handle the families and stuff of the employees while they're employed, or something to that. Now, of course, it's going to need a lot of attorneys to help with that contract to make sure we don't have other, there's all kinds of other issues. But it's a different way to pay for healthcare that's agnostic to insurance that might drive the cost down.
And the difference between direct care and concierge care?
So concierge care is usually as like is more specifically for people. It's usually like they take insurance usually. And concierge care is more about value added. So let's say you have different needs. You want to be seen faster, da 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 da. But you're still it's about like so they're much more. It seems to be about like how to get the most for like helping maximize whatever. For us, it's more about money savings and just cutting out the middleman. Again, it's a little bit arbitrary, and I think some of it just is how I set up the expectations. Tell people like, look, I'm not there at your call and beckon. You're gonna have doctor's appointments with me, right? So if a patient says I want my medicine changed or whatever, I say, fine, let's make an appointment. It just so happens if you're on the membership model, you're paying a flat rate for that rather than that. No, I don't know if that answers the question, but I do have like regular doctor's hours, doctor's appointments, and things like that.
Questions from the audience or from our remote attendees? One question.
Yeah, could you talk a little bit about the transition period from working at a community center to building your own panel, maybe the growing pains and some of the major things that you remember being difficult and maybe developing the panel itself?
How much answer do you want? How much time do we have? So I worked together with Jenny, the consultant, Jenny Byrne, who we're going to hear her video soon. She's amazing. She had me follow this book, and it's called The Pumpkin Plan. It's for entrepreneurs. It actually works. The idea of the pumpkin plan, and I'm going to go somewhere with this, is that it's think about a county fair, right? The big pumpkins. Nobody wants the little pumpkins. Everyone wants the big. But the way that those farmers grow that actually works for any practice, including medicine, right? So what they had to talk about, me personally, like, look into is like, what's my area of innovation? Like, what do I truly innovate? And like, and then how do I find patients like that? So we did a lot. So I did lose a lot of patients. It was slow. It took about 18 months to grow. But what we did a lot of drills, for example, I thought a lot about who are the patients that I truly light up, and not the patients I want to say make me light up. The patients that truly, when I see them on my schedule, I say, oh, good, so and so's on my schedule. What is it about them? And then I made fake avatars, and I did this for like a whole bunch of these ideal patients. And then the idea was I started thinking, where do they go? Where do they get their news? How are they going to find out my imaginary ideal patients? How do they find out how to find Dr. Levy? And then I said, well, let's say, for example, my patients all like Disney. I don't know, it's just me. I like Disney. It's just something about it, right? So I use Disney analogies and Disney references. I'm a geek, right? So my point is that like you kind of, it is a slow period, but you use that, you're going to want to network. So that's the thing, I networked aggressively during that time. And I really thought about who my ideal patients were and how do I find them. And it's a really much a business thing. And to be clear, this does buck against the trend. It goes a lot with what we're talking about with the rest of this conference. For example, as a private practice physician, I have to ask my patients for reviews. And you think, is that, is it okay? I honestly, if I have a patient I really like, I am more inclined to ask them to review me. Is that, we can talk about that. Should I ask every patient? I mean, I'm not, if a patient, I never would discourage a patient from reviewing me, and I would tell them front. But my point is that these are the sort of things you got to think about. And so when I have a patient that I'm like, I'd really like to get more patients like you. I want you to leave a review in your own words on Google for what it is about me. Tell me your story. And I don't tell patients simply, be honest. If you don't like something about me, please tell me up front so it's not on Google. But I don't want to lead you. But this goes back to the idea of you have to figure out who you are. And that's so the transition time is very slow as you lose patients. And you start, but you're gonna need that time to build your own practice anyways in network. That was a very long-winded answer. Sorry.
A question?
So this will be a very wonky question because I have a background in healthcare econ. So, but my question is I'm struck by how similar this direct primary care model sounds to sort of staff model HMOs, where as a like for people here who do not know what that is, some like essentially an insurance company will pay a doctor like a set amount per year per patient, and then that's it. Like there's no billing.
Capitation.
Yeah, capitated payment. And I was wondering if if this direct primary care model is something that like physicians seem to like prefer to our like fee for service model. Is that sort of a direction that insurance should be going in the future?
That is a great question. God, I would love to have more debate about this. Because the answer is, I don't know. I think about that question a lot. Like, if let's just say this is the great way to go, are we just going to be back to where we started? The problem with the capitation models, from what I understand, like classically, is you actually have the other issue, the opposite issue, where you're encouraging doctors to do less, and you're penalizing doctors for doing more for a different reason to save money and stuff like that. And I don't know. There's got to be that sweet spot because on one hand, I'm saying the reason why I'm able to save money is because I run more efficient when I don't have to worry about fee for service. But on the other hand, if everybody, I, I don't know. But I'd love to know other people's thoughts on that.
How does telemedicine fit into the model?
Oh, it's great. It works out great because, well, okay, so it has to do with the kind of the culture, the mentality of direct care model. We tend to be pioneers. I think in general, the people who are attracted as patients to direct care are usually people who see their health as an investment. And because because we're telling people you're going to pay money in addition to what you're already paying your insurance premium to see a primary doctor, to see me, when there could be an in-network doctor, right? So the only people who are really going to go for that right now are people who see that as an investment. And so you do see, and so that when that goes back to that, I think it does tend to skew much younger, and I think it does skew much more tech savvy because the same people who kind of think that pioneering spirit would dig a direct care also think that way. Again, I could be spitballing, but it just tends to be how it is. So it works out just fine for me, and I don't even have to worry about parity. I don't have to, like I said, I can even do a phone call with a patient if it's medically indicated, and I don't have to worry about even doing a Zoom call if it's the right thing to do. If it's just a quick question for a patient, because I'm not billing them for that.
Hi, can you maybe give an example on how you found patients? Like, where did you network? How did you go about doing that?
Oh boy. So lots and lots of networking. And this is private. Again, we'll talk about starting private practice and branding and all that. But so again, I thought about where am I going, my ideal patients, what do they look like, where do they come from? And then I went to the referral sources for that. So every day, okay, when I started, my goal was one new patient a week. Well, actually, yeah, first month was one new patient a month, actually. And I just started with psychology today, but word of mouth, word of mouth, word of mouth, just lots and lots of word of mouth going. I didn't have any patients to see for the first few months when I went live, right? I use that to my advantage. Just use that time. So I would say, all right, my goal is I want to have one new patient a week, one new patient a month, and I'm gonna make 4 new contacts. So then I just go to different, and it's a business expense. So I'd say, look, I like to buy, I'd go up to different therapists and stuff and say, can I take you out to lunch? By the way, if you read the Pumpkin Plan, where they talk about there's actually the question you don't want to ask is what can psychiatry do better? It would be what frustrates you about working with psychiatrists. That's the question you ask. You don't ask, what can I do better? Because they're going to say you're doing great, or they're just going to lie. Or they're going to say something, I say, what's your pain point? Right? But just lots and lots and lots of networking. And when you do get a patient, you thank the referring doctor profusely, right? And doctors love that, by the way. But yes, yeah, it's a slow process. I'm almost 100% word of mouth, and I'd much rather go slow through word of mouth than rush it and like advertise everywhere. I spend, besides Psychology Today, my advertising budget right now and has been and will continue to be $0, and I'm very proud of that.
Question in the back.
You said that this was kind of like a pioneering model. How common would you say this direct care model is right now? Like, do patients that you see still need to have insurance for other types of care that they have?
Oh yeah, definitely. And in fact, yeah, all my patients have insurance. In fact, when I onboard patients, I specifically say, I need your insurance card for when I do prior authorizations, because I still gotta do them, right? I need that info to help me speed that along. So yes, all my patients have insurance. And that is one of the things that's the key with the education is goes back to that value added, like, what is it that I'm exactly providing this patient that they can't get from an in-network doctor? Why should they pay me when they have the option to go to an in-network doctor? I don't know, there's something else. That help?
Okay, no questions from remotes? Okay, then I think let's thank Dr. Levy.